We'll start with our panel discussion for the day, that is on early laryngeal cancer. The moderator for this session is Dr. Prathamesh Pai, and he is the professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. And the panelist for this session is Dr. Akshay Kutpaje. He's a senior consultant and director, Head and Neck Oncology at Site Care Cancer Hospital in Bengaluru. Dr. Dakshesh Patel is a consultant Head and Neck Oncologist at HCG Cancer Center, Ahmedabad. Dr. Giorgio Peretti, Director of the Rhino-Laryngology, Genova San Martino, University Hospital, Italy. Dr. Kshitij Dumadia, Consultant in Medical Oncology, currently practicing at HCG Cancer Center, Ahmedabad. And Dr. Maitri Gandhi, Consultant Radiation Oncologist at HCG Cancer Center. Dr. Prakash Odebra, Radiologist in Ahmedabad at HCG Cancer Center. And Dr. Samir Batham, Senior Consultant in Radiation Oncology, practicing at HCG Cancer Center, Ahmedabad.
Thank you very much. I think we have had a good session from morning discussing about, I thank the organizers for giving this opportunity to ask questions to such an eminent panel. And I urge all of you all to come forth and ask questions as well. We have had good talks on larynx anatomy, the TNM, the various types of histologies that we are seeing, as well as how we are managing it in the modern era today with transoral robotic surgery, transoral laser surgery, as well as the newer modalities of radiation. But there are a lot of issues that we are having with laryngeal cancer, especially glottic cancer. Early lesions are difficult to differentiate. Previously excised lesions are a challenge, and all of us face this in our practice. As we heard, there are similar oncologic outcomes reported, and every few years there's vacillation between one is better than the other. We need to understand that every year we are having more meta-analysis, systemic reviews, but it is like comparing apples and oranges. You saw today's talk by Professor Peretti. There is such a wide variation even in the T1 and the T2s that you really can't compare and say that this is better than the other. And more importantly, there are very few centers that have proper resources for all this high technology-driven treatment that we will require in laryngeal cancer. So looking at it broadly, I felt that there are a lot of issues that we have. Assessing a cord, calling it an early lesion, excision versus radiation, which is the often debated topic. What are the adjuncts in management? The AccuBlade versus microspot, use of frozen sections. The need for an adjuvant therapy, we heard about it, how we still might require adjuvant treatment, and of course, management of the neck. So we come to the first case. It's a 35-year-old smoker. Both cords are mobile. And this is the kind of lesion that we will see. So I would like to ask the surgeons in the audience, to give us pointers towards how they will evaluate early glottic cancer during a microlaryngoscopy. Professor Peretti, I will like to start with you. We are all in our careers learning along the path of how to manage, how to evaluate. But you have such a vast experience of over 4 decades. Can you tell us how do you evaluate during a microlaryngoscopy? What are the techniques you do to evaluate a suitable case? You said in your talk about the depth, the extent. How should one go about evaluating a case for surgery versus a non-surgery?
Okay, the first evaluation must be done in the office, because in the office you have the possibility to evaluate the mucosal wave, the mobility of the cord, and the arytenoid, that are two different tissues. And with the aid of bioendoscopy, you can also presume the histology. For instance, with NBI, because based of the morphology and the atypical vascular pattern on the vascularization, you can presume if there is some change as a dysplasia or carcinoma. Then you go in OR, and during microlaryngoscopy, I always use routinely the evaluation with the angle telescope, with 0 degree, 70 degree, 30 degree, just to evaluate the superficial spreading of the lesion. Again, I repeat the bioendoscopy to evaluate also the surrounding tissue of the lesion, just to understand, to have a very precise idea about the superficial spreading. In this case, probably superficial lesion, very bulky lesion, but superficially without any atypical vascular pattern in the surrounding. I don't need imaging. I don't need, because probably is a mobile arytenoid, mobile vocal cord, and without any atypical vascular pattern. So in this case, I perform one-stage procedure, making...
We'll come to that.
Okay.
We'll come to that.
Okay.
So I want to ask, Akshay, would, like Professor Padetti said, that we may not require an imaging. So traditionally, we have been taught to do an imaging first and then do any invasive procedure like microlaryngoscopy and all. So do you actually do a CT scan, or do you do any imaging prior to evaluating these patients in the OR?
So in early glottic,
And then what would be your guidelines for that?
so in early glottic cancers, there is no role of imaging for any lesion which is going in the free edge. On a Hopkins scopy, you see it's a T1A kind of lesion, mobile local cord. Which are the lesions of early glottic cancers which requires imaging is those lesions which are bulky, which goes to the anterior commissure with subglottic extension or going in ventricle with restricted mobility. It is not only important, and specifically when you are looking for imaging, you are asking the radiologist or the technicians for an imaging, what you have to ask for a really close cut, like 0.5 mm or a 0.4 mm cuts. And also as surgeons, or when we are looking at imaging, we should also not only look at axial sections, but also sagittal, especially for lesions going to the anterior commissure, to look for those subtle extrathyroidal extension which goes through the cricothyroid membrane.
We have a radiologist with us. Sorry, I didn't get your name again.
Dr. Prakash.
Dr. Prakash. Can you tell us what is the imaging of choice if we have to do an imaging, like Dr. Akshay was telling us? So if we ask for an imaging, what kind of imaging would you do, and what is the kind of reporting that you would do for us?
Okay. So if you are looking at this lesion, this is not...
Not any glottic cancer. Now, Akshay refers to you for a CT scan. What kind of CT scan would you do?
Okay. So the advantage of CT scan is that it is quick, so the motion artifacts are less. So that is one advantage. But based on what you want to evaluate on imaging, will decide whether we should do a CT scan or an MRI. If there is a tumor wherein you want to evaluate just local area without much extension outside, you can go for a CT scan. But if you want to go into much detail of soft tissues, then you need an MRI as well. So personally, I would say an MRI with contrast for any laryngeal cancers, along with a plain CT scan of the neck. If you combine these two, that becomes the best evaluation of the patient. But that depends what answers you want from me, right?
So what kind of, if we, now all modern CT scanners are multi-detector.
Yes.
So what is the kind of thickness that we would aim for, and what should we ask our radiologist?
So 0.75 mm is the thickness we go about, then that can be easily recon in multiple planes, and
Right.
then whatever answers you want, from that we are able to give.
Right,
Less than that thickness, sir was asking of 0.5,
right.
but that I think is not needed. 0.75 is the standard one, and then we can recon in sagittal and coronal planes from an axial plane, and then we can see the extension based on where the tumor is.
Do you have any experience with the neo modalities of radiology like optical coherence tomogram? Would that be a better modality for us? If there's any other panelist who has experience in this also?
No, we at our center we don't have that experience.
Professor Peretti, Akshay, Dakshesh. Because there are some reports that come in that you might be able to see more like a photomicrograph imaging like you have in the ophthal. So they can get entire sectional imaging. So any experience? Okay.
No, can I make a point about the...
Yes, Dakshesh.
So Professor Paretti said about the examination in office. So because smoker and in our population we see a lot of submucous fibrosis as well. So that office examination with a Hopkins will tell us about what we need in the OR when we are going to do the direct or the microlaryngoscopy, because many times the mouth opening is not so good, and we may end up having, like, if we don't have that 30 degree, 0 degree or 70 degree scopes in the OR, so that setup has to be kept in mind while doing the oral cavity examination and the mouth
So
opening.
that's a good point. So this brings us to the role of laryngoscore. So we, yes, please.
Morphologically, this is an exophytic polypoidal, well demarcated T1. Now suppose you have an ulcerative erythroplakia, leukoplakia combination of T1. Would, to you as well as the panel, would your approach change?
In terms of imaging?
In terms of, everything, because I feel that these are two separate biological,
Right, right.
dimensions. And I just want to know from the August panel as well as you, that will your attitude change?
So you're talking of treatment, sir.
No, not treatment, even for evaluation.
Evaluation.
Like, this is a very well demarcated, we are agreeing that probably we may not need a CT scan or
Right.
something like that or this. So if it would have been an ulcerative lesion with erythroplakia, with leukoplakia combination, would even the assessment approach of a particular tumor would change? Certainly the biology is different. So I don't know, I'm asking questions.
Yes, sir. Yes, sir. So the question is, if there was a ulcerative lesion or a lesion with multiple areas of leukoplakia, dysplasia, how would our evaluation change in the OR?
So it's very important to geographically kind of understand the lesion, not only in terms of extent, but also in terms of the depth and so on. So if you have a lesion which is bilateral, okay, and in that situation you would stage the procedure and so on. But I think in terms of difference of how I would approach a lesion, if it's an early glottic lesion, it is if it's an unilateral versus bilateral in terms of in the superficial extent as well as deep extent. So if it is in the geographically it is extending on both sides, I would kind of look at the lesion under microscope and address the lesion which looks under microscope a little more like more cancerous or in comparison to two, and stage it accordingly. Depth is another important factor I would look into, take into account while going for a therapeutic approach. Also in terms of extent, like if it's a posterior place lesion, going to the arytenoid, going to the posterior paraglottic space, again those findings, I would decide whether to go for a laser surgery versus do a biopsy and consider certain other modalities of treatment based on biopsy.
Anybody else wants to add anything?
For sure, the differentiation, in my opinion, is based on bioendoscopy. Bioendoscopy is important tool to differentiate erythroplakia from leukoplakia that are clinical definition. So when I look a lesion, I look more on vascular pattern than the macroscopic appearance of the lesion.
Right.
So maybe sometimes you have leukoplakia without any atypical vascular pattern. In this case, maybe I can wait and see the lesion. In other cases, I have a small erythroplakia with some atypical vascular pattern, multifocal spreading, and this changes completely my approach to the lesion.
Okay.
So the bioendoscopy is essential in my workup.
So, yes, so it is very important to understand what is the lesion that we are seeing on the flexible laryngoscopy. And in the outpatient itself, that's where your evaluation starts. You will actually know where that lesion is. You want to know what is the type of lesion it is. Then you can plan whether you want an imaging upfront. And lastly, during microlaryngoscopy, you will then pay more attention using other adjuncts to know where is the lesion and what is the surrounding vascularity. Yes.
So a comment is there is a purely a lesion on vocal cord, and there are leukoplakic changes in the surrounding areas or the opposite cord or the surrounding areas. How would you approach it? Like there is a frank growth on a vocal cord.
We are coming to the treatment later, so we'll come to that point.
Yeah.
So I just want to bring this up. Professor Peretti, who better than you to tell us about the use of laryngoscope? All of us want to do microlaryngoscopy, but we do not end up assessing the patient before it comes to the theater. And at that point, we are then stuck because we cannot reach it, we cannot assess it adequately. You mentioned today that you would require different types of scopes apart from assessing the patient. So can you just elaborate on these two aspects?
The exposure is the key of success of transoral laser microsurgery or even robotic surgery. So if you have no adequate exposure, you have probably to change your therapeutic option. So it's very important in the preoperative counseling to evaluate how will be the exposure based on different parameters that you can summarize in a score. So when you have a high score, that means you face with very difficult exposure. Sometimes you have to limit your indication, even if you use a very small laryngoscope. And you take into account that if you use a very small laryngoscope, you need more skill because it's more difficult the procedure. So my suggestion is to evaluate very carefully pre-operative before going to the OR, the possibility to have adequate exposure before proposing to the patient, okay, this I can manage with TLM, because otherwise sometimes you go in the OR and you have to stop your procedure.
Right. So this, I would urge all of us to read this article and actually use it in practice. It's very easy to apply this score, and it will be very important for you to have it in your OR, in the OPD, so that by the time you're planning for doing a scopy, you would have assessed whether you would actually complete the scopy and do the procedure. So it's very well labeled as various classes, and it is up to us to actually understand which of these patients will go on to have a complete exposure and treatment. So what we have learned so far is that we would need to assess in the outpatient, we need to plan the proper imaging and the scopy, use a laryngoscope, and assess where is your lesion. We saw about how there are different types of the vocal cord lesions, whether it's a mid-cord lesion, the entire cord involved, anterior commissure involved, and extension beyond. Everybody talked about assessing the depth. How do you assess the depth? in your microlaryngoscopy. Akshay, you said that you will be assessing the depth. Kshitij, Dakshay also please pitch in. Akshay, let's start with you.
Yeah.
How do you assess the depth of that lesion in your microlaryngoscopy?
So the depth can be assessed by two ways. One in a gross way by using a blunt suction tip and kind of rolling the lesion around and see how it is kind of moving in relation to the deeper structure. The other one is the saline injection using a scalp vein set and infiltrating it just below the lesion and see how the lesion lifts up from the bed. If the lesion lifts up from the bed, that means it is above the ligament. If it gets stuck, then the extent of resection is going to be at least a subligamental resection. So by doing a infiltration of a saline deep to the lesion.
So you would do that in all your cases or only in the cases which you have?
So in practice, I actually don't do this lesion because my minimal resection for an oncological is a subligamental. So I don't do these things. So
right.
Since because you are using laser and you are doing under microscope, it's very, very precise. And the reason which I am doing is more technical because there is a little bit of bleeding spot and kind of, that is the reason technically I am not doing this technique.
So you would assess your lesion based on the ability to do suction on the mucosa and whether it is pliant or not. Professor Peretti?
I used to combine video stroboscopy in the office because the absence of mucosal waste is an indirect sign of the infiltration of the lamina propria, combined with the infusion in the Ranke space. Of course, if I have a normal mucosal wave, I have a complete ballooning of the epithelium and no evidence of atypical vascular pattern. Very selective cases, I perform a subepithelial resection because the lesion is included in the epithelium. By contrast, if only one of these three parameters are negative, I have no ballooning, I have absence of mucosal wave, I have some atypical vascular pattern, I go straight for subligamental chordectomy. Even also because the vocal outcome after type 1 and type 2 are comparable because the closure is complete after the healing process. So it doesn't make sense to take a risk to have a positive demargin with the comparable vocal outcome.
So, yes, Dakshish?
Just about the stroboscopy. And the other thing which we always, like Professor Peretti said, for the free edge and other lesions, he will not have imaging. But it is better to have imaging because in case if we are missing some of the deeper extension, that will be obviously visible in that. So intra-op examination as well as imaging will tell us about the deeper extension.
Okay. Dr. Kshitij is there? He's not there. Okay. Oh, he's a medical uncle. I'm so sorry. But you can always contribute. I will be asking you all, okay? So the point is that if you have a lesion which is to be assessed, there are various other modalities to know the depth. You may use infiltration. You might use the stroboscopy also as a means to understand the mucosal wave. Way back in 2001, this publication came from the Zeitel's group in in Massachusetts, and they showed that the stroboscopy is not reliable to differentiate, but it is able to determine the depth only in the superficial lesions. The relative normal mucosal wave suggests no extensive invasion, but then your final call will be taken during surgery. And the video stroboscopic ratings, whether it is normal or present or it's you cannot comment, are very subjective. So you need a lot more studies to actually have a very good comparative, reliable parameter to judge whether it is actually going to be mobile. So you need to have your clinical judgment along with your infiltration test to understand whether it's truly a mucosal or it's gone deeper down into the ligament.
Yes.
Of course,
For this reason, you have always to combine stroboscopy with infusion and
Yes,
MBI,
right.
not only one
Not only one.
examination.
right. And there might be some who might want to go in straight for a subligamental resection because it's an oncologically more safer surgery. So this was a systematic analysis also, which talks about the same, that the sensitivity and specificity are good but not good enough. It could identify almost all patients with cancer, but only 2/3 of the patients where there was invasion into the ligament. So my question to you now is something that we all come across. A patient comes to us who's 40-year-old, who's got hoarseness for the past 3 months, and he's a smoker. Both cords are mobile. CT scan done shows no paraglottic space involvement. This is the imaging seen on video laryngoscopy. What should we do? Should we do a biopsy? Should we excise it? And how do we go about counseling this patient for one or the other? The surgeons.
Okay, the CT scan means that no paraglottic space involvement, means also no infiltration of the muscle.
Right.
Okay, so in this case, if you look at the vascular pattern, you have some dilatation of the vessel in the posterior part. You better see with MBI. There is no involvement of the anterior commissure, okay? So in this case, I don't need a biopsy. I go straight for subligamental cordectomy, one-stage procedure.
Dakshesh, Akshay, y'all practice in a multidisciplinary clinic. So y'all actually do a biopsy or y'all excise?
I would do a biopsy first and then take the decision of. Most commonly it is going to come as a positive because of the history smoker and looking at the lesion, but I would do a biopsy.
So you'll take the patient up again for surgery if the patient
Yes.
then opts for
Yes.
transoral laser.
Yes.
Akshay, what do you do? The audience, anyone, any comments? After you. Yeah. Akshay.
I also do as Professor Peretti does. So, I mean, we have a tumor board, and I did have a lot of resistance when I started doing early glottic cancers. But we cannot take, in our patients, it's very difficult for us to take these patients again back to the theater. And we know that T1A glottic cancers, through various lectures, has shown that it gives equivalent oncological and reasonably good, it gives an optimal functional outcomes. So what I used to do is,
Then how do you counsel the patient?
So the counseling to the patient is that, so this clinically looks like a malignant lesion. There is more than 95% chance that it is going to be malignancy. And by a single modality, we'll be getting both diagnostic as well as therapeutic treatment for you. You just have to come to the theater, 30 minutes of procedure, and you will be back home the same evening. So and with good outcomes, at 3 to 4 months, you have a good voice, and you'll be able to get back to whatever work, except if patients are professional voice users. If it's a singer, I mean, I hardly had seen a singer who...
I'm a bathroom singer, even I need my voice.
Like a professional singer. But generally my counseling is that it's both therapeutic as well as diagnostic, and it doesn't impair your functionality of your voice.
So the radiation oncologists have no role in this?
No, so that's why I'm pitching in. So this is looking in a bit anterior lesion, and I would not agree with him. Definitely a biopsy is must, and then
But why
the patient,
anterior lesion?
This is looking anterior, although
No.
the commissure is not involved,
So how
but it is
does
going anterior.
How does it change?
So because the paper which was quoted by a ma'am, I guess there was a subset where it was proven that particularly for the lesions who are located anteriorly and involving anterior commissure, the voice quality of radiation is far better than surgery. So if this would have been a posterior or mid-cord lesion, I would not disagree with him, but for anteriorly situated lesion, I would say that yeah, these patients should be discussed in MDT before choosing the final treatment.
So can
this is
the reason for not jumping to the modality wherein you excise and do all procedure at one, and the reason for doing biopsy first is the counseling, because cancerous versus not cancerous, even if we say it is 95%, 99% or 100% is going to come positive, it is important for the patient to understand the disease, the process, to meet a radiation oncologist as well, and then take the decision about what is going to do next. So for that reason, it is important for the patient also to know whether we are dealing with proper cancer or not. That's why the biopsy first, and then we do.
What about the cost implications?
So that is another. We are talking about the medical aspect first. Cost is always there.
But then, when Professor Paretti and Akshay do it, the cost is one.
No, cost is always there. We can always see now. Is a male 40-year and billionaire. Let's put it in that way.
Yeah, he's not a millionaire.
So,
Yeah, doctor.
Typically at our place, this patient will come to the tumor board before biopsy. Any
Straight
patient,
away.
any patient seen in the OPD, new patient, he comes, especially these kind of patients, we can discuss in the tumor board. There is a strong possibility of cancer. This is just one image. Most probably the anti-commissure is totally free, as I understand.
It is free. It's completely free.
So when that video is shown, the NBI is shown, we can discuss in the tumor board and then counsel the patient. If we can say that 95% chance that this is malignancy, you have two options. One, we can do a small biopsy, prove it, and then you undergo radiation. These are the pros and cons. And the second option is do the excision biopsy with negative margins with laser as one go, have the diagnosis as well as the treatment. Most probably you will not require any other treatment, and you can have follow-up.
Dr. Dev?
yeah, no, my question is, suppose you have done a small quote-unquote biopsy, it's in depth really a cancer and the biopsy shows negative. Number one, and number two, if you are going to do biopsy, just put that lesion back again. If you are going to do the biopsy, from where are you going to do the biopsy? Are you going to use any dyes to understand the correct area of the biopsy? And if the biopsy is negative and the patient disappears, what are you going to do?
It is important point that the concept of biopsy, because if you take a small biopsy, the biopsies could be not representative of the entire lesion. So the concept of a seasonal biopsy is to remove the entire lesion, to have a diagnosis of the entire lesion, not only a small piece of tissue that could be false negative. And also, if you perform just a biopsy, to be sure, you don't need any more, because the accuracy of the bioendoscopy is so high, it's more than 95%. So you can presume in preoperative setting or intraoperative setting the histology of the lesion. And with seasonal biopsy, you remove the entire lesion, you have the accurate diagnosis of the lesion and the treatment in the same time, without any damage to the vocal outcome, because it's proved that if you perform subligamental cordectomy, the vocal outcome is comparable to the normal voice. This is the problem where we compare radiotherapy and laser. It's not a laser. You have to compare radiotherapy and the type of cordectomy. Otherwise, you present MRT and the laser, but it's not the same things.
Right.
Okay?
Radiation oncologist.
Can I make a comment? Can I make
yes.
a comment? Yeah. So I agree partially with what Dr. Dakshesh and Kaustubh sir has said, that we would do a biopsy, we would do a MD discussion for a lesion like this, and as you can see in the upper lesion, we would be very sure that we would go for an excision for the lesion we just seen up
Above, yeah.
Yeah, above one. And for the lower one, I would absolutely agree with Dakshesh. We would do a biopsy, because patient has all the rights to know whether he or she wants to go for a radiation therapy or go for a complete cordectomy. Because whatever the literature says.
Not complete cordectomy.
No, not complete, but I mean the cordectomy or a partial cordectomy. So before going for the treatment, they should know what they are dealing with. So for a lesion like the down picture, I would prefer a biopsy, and the picture like the up one, I would prefer excision straight away.
Okay. Dr. Maitri, Sameer, what would you do? How do you all counsel? They said that they'll counsel that it's a one-stop treatment and I'm going to remove it and patient's going to be fine, your voice is going to be good. How do you counsel when Madam, let her answer.
Okay. So basically for this, I would, in our setting also, we always do a multidisciplinary discussion. And definitely for this lesion also, I would like to go for a biopsy first and then discuss the pros and cons of both the options with the patient and let the patient decide what he wants.
So in the MDT with Dr. Kaustubh, how do you all actually, battle it out? Who's going to treat? Not just because Dr. Kaustubh is who he is, that he's going to win every time.
No. In our multidisciplinary tumor board, we would discuss this. The problem is we don't get these patients. The problem is somebody has done a biopsy, right, and the patient comes, and then that's a whole lot of another
That's
issue.
another
Yeah.
discussion itself.
So usually if this patient would have come, we would discuss. More than discussions amongst us, the discussion would be with the patient.
Right.
I know.
That is what is the most important thing, I would say.
And Prathamesh, basically most of the center doing this surgery has a frozen section facility. If at all, we can counsel the patient that we'll send a frozen section. We'll have to wait for some time till the frozen comes. And then the plan which is already discussed by the patient, either way can be discussed. So frozen section is still a fallback.
Right. So we discussed that. Dr. D'Cruz, you want to add something? You're coming closer and closer to the mic.
I'm not understanding why you all are prolonging the agony so long. When you look at guidelines, a patient can be operated. I think literature now says if you're doing type 3 cordectomy or less, laser is the treatment of choice. You salvage or you save more larynx, voice quality may be better, you can salvage these patients. So if your treatment philosophy is to do laser, just go and remove it. If your treatment philosophy and you don't have the laser for a mid-cord, both these lesions are laserizable. I'm not going to do biopsy for one and talk to the patient. Patient will say, what's good for me, you do. To me, it's good for laser, both cases. I would just do laser.
Okay. So now we come to the other lesions. You have got the T1s and you have the T1s. Both of these are T1s. Now, which cases in the joint clinic would you then discuss for a treatment of laser versus radiation? Does speech, oncologic outcome, and cost make a difference to you? Radiation oncologist.
As Maitri also said, and at our setup, all these patients are of course discussed in MDT. And for the treatment, of course, as in fact was shown in Sarbani ma'am's presentation, there are multiple factors. There are patient-related factors, there are disease-related factors, their finances. So all these things we usually take into account. And as Sir said, it is the most important is what our patients want. How is the demand for voice? And then we usually take these calls. So if you talk me this, then what my discussion will be, let it be that, so I'm not going to win, but my argument will be for any anteriorly situated lesion, I would definitely prefer radiation over surgery.
Maitri?
So if you are talking about the speech oncological outcomes, I think the trials have shown comparable results for the effectiveness of both the things. And even for the cost thing, I think even the conventional fractionation is enough, and the conventional techniques are enough, which hardly cost few thousands. So I don't think that cost is also an issue when we debate about the laser surgery and the radiation.
Dr. Paretti, you would then do laser for everything. When would you send for radiation?
The criteria differentiate the choice between laser and radiotherapy, talking about early glottic cancer, is the involvement on the anterior commissure, because if the anterior commissure is involved, the voice is worse with surgery compared to the radiotherapy. And of course, the exposure. If the exposure is bad, I go for radiotherapy or the surgery. If you take into account the cost, I cannot understand because you use the radiotherapy for a small lesion of the middle third of the vocal cord when you can use radiotherapy for other cases. And you have to take into account that when you send the patient for radiotherapy, you need the biopsy before the radiotherapy, and with the laser you can, in the single procedure, unify the treatment and diagnosis. And you have to take into account also the social cost, because in a half hour I can solve the problem. If you send to radiotherapy, it takes 6 weeks, and you have to take into account also the social cost of the patient.
Okay.
Prathamesh, can I just say
Yes,
something? You know, when I see lesions like this, what is most important for me as a radiation oncologist is to ask my surgeon, how likely is he going to be able to get, what is the extent of excision going to be, and whether he's going to get negative margins. If he says both these criteria are going to be fulfilled, I really will not argue with my surgeon about going for the per primum excision of the tumor, because I agree to what Dr. Paretti is saying, that we have to talk about cost implications, and we have to talk about the duration of the treatment also with the patient. So typically we are also arguing about these, or we are rather discussing these patients. So typically I want my surgeon to give me negative margins. I don't want 5 millimeter margins in the larynx, but I want at least a millimeter margin. It has to be negative. It should be less than a type 3, because then the voice outcomes are going to be better. And that is what is going to push my decision of radiotherapy versus surgery. Because this is something that is always discussed in all larynx meetings, about surgery versus radiotherapy. A mid-cord lesion is everybody wants to take up that patient. But at the same time, if you think from the patient's point of view, I think these are the considerations that the oncologist needs to make in terms of the patient.
Yes, completely agree. In fact,
can we go back to those two figures?
The treatment is a unimodal. So if you go for surgery, you go for free margin resection. This is a reason because you need a good exposure. You need a very accurate workup to evaluate the superficial spreading on the lesion. And the important things is not how you extend superficially the lesion, but how too deep you extend, because you can remove all the superficial layer and you don't impact the vocal outcome. The vocal outcome is related to the deep extension of the resection.
Right. Very well put.
So these two are exactly opposite in my sense. The right-sided lesion, I would like to evaluate much more carefully. I would like to have a biopsy. I want a diagnosis and consultation because it goes to the arytenoid. It seems that it is going on the arytenoid posteriorly.
Right.
And this, if we try to excise with laser, will definitely have a poor outcome. So the right-sided lesion is something where you definitely need MDT and also the counseling with the patient. If he wants surgery, then we will have to tell him that these are the consequences.
So the point that we are debating seems to be very, yes sir.
In the right lesion, I want imaging.
Right.
Definitely.
Right. So we are very clear that these are apples and oranges. You need to be very clear, apart from all these things available in literature, what is your capacity? So we heard from Sarbani, she wants us to give a clear margin. We heard from Professor Paretti that there are certain areas that you need to be very vigilant about, the anterior commissure, the posterior commissure, the arytenoid, the cricoarytenoid unit. So it's not just that you can do a laser, it is how experienced you are. It's not just whether you can radiate, it's how experienced you are to give radiation, because both have got problems. So we need to select out the right case for the right treatment. If you are competent, you have the resources, you have the machines for doing that treatment, yes, you should. But please do not do an excision for these and then send it to the radiation oncologist, or radiate it and then send for a salvage, because both times the patient is going to fail. So let's move on. This is for the surgeons. What kind of methods of resection would you recommend? We have been all taught to consider doing the Steiner technique, where we go through the lesion, assess the depth or the base, because the deeper margin is always of a concern. Or do you then do a circumscription, like everybody says now, the robotic surgeons claim they do an R-block resection. So everybody goes and tries to do an R-block resection. So what is your advice to us?
So in terms of methods of resection, it is proven oncologically by work done by Professor Steiner that even if you do segmental resection, it is oncologically safe. But you do segmental resection for large verrucous type of lesion, where you may not be able to visualize the entire lesion on suspension laryngoscopy. If it is a small lesion, you do an excision like a circumscribing one. However, when there is a larger lesion, more like a verrucous lesion, then you do a transtumoral and then do a segmental resection in parts, depending on how you want. Certain times, you may have to reposition the endotracheal tube to do the posterior resections. That is how I would approach.
Completely agree. I go for excisional biopsy for flat lesion when you can control very well all the margin. If I have infiltrating lesion with impairment of the vocal cord or bulky lesion, I cannot control the deep margin. I prefer the Steiner technique. But the problem of Steiner technique is that you need a very close relationship with the pathology, right, because you have to discuss with him the orientation of the specimen, you have to mark very well the margin to be examined, because you don't need to evaluate all the margin, but just the deep margin or the anterior margin. So sometimes I invite the pathology in the OR just to discuss together how to send the specimen.
Professor Peretti, we know from the European Laryngology Society this classification. Now, oftentimes, we do not know, everybody says that I'll do a type 1 or a type 2, but this is post-resection classification. So then, how do you exactly counsel your patient when you are seeing the lesion in front of you, and then in our joint clinic when we are discussing that I will be able to do a subligamental or I will do this type of resection? So when should you actually apply these classifications?
In the counseling, if I have the idea or I plan type 1 or type 2 according to the accurate workup and so, I can say to the patient, okay, we go straight for the surgery, and it's a unimodal treatment. The patient will have a good voice, so good compromise, good balance between oncological results and functional results. Type 3, you reserve when somebody send me a patient with a biopsy already done. So this is an alternative to radiotherapy, but the vocal outcome is compromised a little bit by the incompetence due to the more deeper resection. The other chordectomy, type 4, 5, 6, are alternative to open surgery. And of course, in these cases, I need the histology before to perform this chordectomy, because for sure I will have a compromised voice, and I have to discuss in multidisciplinary team the alternative. So this is just a description and not an indication.
Not an indication, right. So coming to margins, in laser surgery for glottic cancers, what is the margin you would aim for? Would you use a frozen section in all your procedures? and what should we practice?
In the vocal cord, if I have 1 millimeter of free margins is enough.
So how do you know that it's 1 millimeter?
I note with superficial margin, mean I just to remove as much as possible superficially. So I perform ventriculectomy before the cordectomy just to evaluate the lateral extension, and I remove all the mucosa until the bottom of the ventricle, at least as much as possible subglottically. I include always the vocal process posteriorly. I reach the anterior commissure without transgressing the medial line.
Right.
So it doesn't make sense to spare 1 or 2 millimeters of the mucosa, because you have to take into account that during the processing you have a shrinking of at least 1/3 of the specimen. So you look at the microscope, you have a 2-3 millimeter of free margin, you send the specimen, and the pathologist cannot recognize the margin, the free margin, and send you have a closed margin or positive margin. But if you look at the literature, you have 30-40% of positive margin after laser surgery, but the majority are false positive.
Right. So
this
you
is
said
important to have a dedicated pathology in this surgery.
So it is very easy for us to see the mucosal margins, anterior, posterior, lateral and inferior. What about the deep margin?
The deep margin is based on the workup. Again, if you have, superficial lesion with no impairment of the vocal cord, you go with subligamental cordectomy. Of course, the deep margin, you remove just a rim of muscle just to give to the pathology the possibility to evaluate the infiltration of the muscle. If you have impairment of the vocal cord, that means that probably 2/3 of the vocal muscle are involved. You need the imaging. So you have to know preoperative how deep is the invasion based on MRI, multiparametric MRI. In this case, I go maybe with transtumoral resection, and the different interaction of laser between the laser and the tumor and healthy tissue give me a precise idea about the deep margin.
So we know that if you have a deep margin positive, you might need to do a relook surgery or need to consider adjuvant therapy.
If I have deep margins, depend. If I have still some muscle, I can make a resection. But if I already done a total cordectomy, in my deep margin, if the cartilage, I cannot go for a resection. So I have to shift to open partial, or if I am confident, I can make a very close follow-up, combine endoscopy, MRI, periodic MRI for at least 1 year. This is a big problem.
So I draw a parallel between tongue cancers and laryngeal cancers, because both are muscles. And we know from our experience that if I resect and I have a positive margin, it's very unlikely that I can re-resect and get a negative margin. So does that hold true in the vocal cord as well?
Yeah.
And then should I then depend on a frozen section during surgery if I have a deeply infiltrating vocal cord lesion?
Yes, but the frozen section is just a point, no? Because you make just a punch biopsy. So if I prefer to make all the layer of the margin and send in definitive, just to be sure. But when you look in the microscope, you have the sensation if the muscle is infiltrated or not. So if there is infiltration of the muscle, of course I go for total cordectomy, including the inner perichondrium. So if the inner perichondrium is positive, I have to change the policy. But maybe the indication was not correct.
Right, right. Okay. So I would like to also ask now, what is the role of narrowband imaging intraoperative? We talked about narrowband imaging in assessing the lesion, but how do you actually use it intraoperatively to take your mucosal margins?
NBI, in my experience, is essential because you can use NBI with an angle telescope. So you can evaluate very precisely the anterior commissure, the subglottic extension, the lateral extension. For instance, with 70-degree telescope, you can reach the bottom of the ventricle, so you can evaluate the spreading. So you have to use always multi-prospective view with NBI before starting your resection, because it doesn't make sense to use the NBI after the resection, because you have a bleeding and the light is absorbed from the blood.
And another problem is that we never get the narrowband imaging through a microscope.
No, you have to use...
so you have designed and you are doing some surgeries using the endoscope with the NBI. Can you tell us about that?
No, I use the aesoscope. There's different things, but this is always I combine the two examination, the NBI with the rigid telescope, and then I put.
Then you always use a microscope.
And then I use a microscope.
Akshay, any comments? Dakshish?
I don't use NBI.
Okay.
We don't have an NBI.
Right. Okay. So now the last question.
You can use other bioendoscopy, I mean, eye scan or something like that. Just the concept is to have more information about the biological findings of the lesion, not just the macroscopic appearance, but take a look about the vascularity, because the change of the vascularity means the change of the biology of the tumor.
Okay.
Do you,
so
sorry,
the
sir, do you routinely use NBI for all patients who are candidates for microlaryngeal excision?
Yes.
Thank you.
Okay, so the last question that we have only about 6 minutes left. This is an often case scenario that we see. Patient presented with an excision biopsy done at another center. Now the report comes as a malignancy and presents to us 3 weeks later. So we are seeing this, that there is some irregularity on the mucosa. The patient's voice is hoarse, but not really too bad. But we are not seeing a lesion. So what should you do? We have no information about the margins. We don't know about whether it has been removed completely. And this is the common situation all of us will face. So what should be the advice to the audience? How should we go about planning? Should we resect it? Should you send for radiation? Because oftentimes these patients are brought to the multidisciplinary clinic by the radiation oncologist because the patient has been directly referred for radiation. Radiation guys first and then the surgeons.
So I would like to send the patient to the surgical oncologist again and just explore regarding the options, that whether further, if any further excision is possible, or if they want to do any surgical procedure. But otherwise, if it's if they are unsure, if they are not confident about it, then definitely I would like to treat with radiation.
So probably these are the patients Kaustubh sir was talking about, and yes, this is common. The problem is clinically we are not seeing anything, so what will we re-resect is the question. And of course, considering the fact that the patient is likely to fail again, in our MDTs we usually consider these patients for radiation.
So the patient comes usually within a week of excision because the biopsy has come positive, and maybe the operating surgeon has not.
The patient has now come from Madhya Pradesh to you.
So that's why, but that is, so this is the one situation. The commoner situation is patient presents when the wound is still healing.
Okay.
Right? And that time we don't actually know whether the residual disease, see, here the mucosa is nice, everything is healed. So in these cases we definitely wait for a few weeks more and keep the patient under observation, maybe use NBI and troposcopy sequentially to know and to see whether patient is not worsening at least. And then decide about, and of course, talking with the operating surgeon, whether it is being done by an ENT surgeon who routinely does the microlaryngoscopic surgery and excisions, whether he has taken any margins or not. All those things will come into a picture, and then combine all those things together and take a decision.
Prathamesh, if this is the correct picture, I don't think that this mucosa is nice. If you see carefully, anteriorly there is thickening. It may be healing process, I don't know, but I will not call this mucosa nice. Though I am not a very nice person, still I would call other vocal cord nice, and then I will compare, like, whether this is really nice or not,
Yes, the problem is that after 3 weeks is not enough, because the healing process takes at least 8 weeks. So I wait for 2 months, and then I see carefully the patient after 2 weeks with MBI. If there is some alteration, I can send for radiation, or I make a re-resection. The problem is that in these cases there was not evaluation of the margin, so it's the high-risk patient, because I don't know which kind of procedure was done. Okay.
Absolutely.
But anyway, the decision must be taken after 2 months, after the complete healing process.
So the point is very clear. Yes, sir.
Yeah. So, in practice, most of this patient will go for radiation, because it's very rare for a patient to understand, to wait for 8 weeks and understand the consequences. Most of the patients will say that I want radiation. And that's what is, and that's why we say that these patients are having bad outcomes because of the first wrong decision.
Because of radiation?
No, because of the first wrong decision of treatment.
Right. So I think the point is very well taken. Yeah, Akshay.
So I think this is a patient we should not give radiation, because this is a situation. It most ideal would be to speak to the doctor and get the first endoscopic picture. So typically these are T1A kind of lesion, and if you look at series of patients who have gone a re-excision, about 30% of patients doesn't have disease. So we may be unnecessarily radiating significant number of patients without disease. Just the biopsy, even though it is not an oncological, histopathological biopsy, but this would have been a curative for the patient. But I wouldn't recommend that not to give any treatment for this, but this should ideally, in my hands, goes for a laser examination under anesthesia, laser excision, and about 30 to 40% won't have disease in these kind of situations.
Most of the problem is most of the patient will not understand this. That is the thing, because they have been sent for radiation by the primary surgeon, and the patient is coming to your multidisciplinary clinic, and when you counsel these patients, 9 out of 10 patients will choose radiation, go ahead with radiation. That is what you are saying is ideal. What Dr. Paretti says is ideal. You have a close follow-up, you have him re-examined, and then intervene after 8 weeks or 10 weeks. But this is the practical situation.
But I have the same experience. I have a 30% of PT0 in the rear resection. So it means that I send the patient to the radiation for no diseases. So it's an important thing to explain to the patient.
One important thing is to really assess how compliant is the patient for follow-up. So if you feel that the patient will not be coming for close observation, then definitely I think he should be sent for radiation.
And in fact, from the discussion, what I understand that majority of the patients are likely to have a residual disease.
Right.
So 10 of 3, the 3 will not be having disease. Is this what you're saying?
Yeah, but then
but the 7 are likely to have a disease. 7 we cannot.
Always look at the cup half full, right?
So this is 70-30, not even half.
The last question.
That too. Just last comment. Last comment.
I'm just asking the medical oncologist, what is the role of chemotherapy in early laryngeal cancer?
Yeah, okay, thank you for asking. Yeah, so as of now, not to be given outside the context of a clinical trial. That is what I can tell. I've got wonderful outcomes with surgery or radiation. So no role as of now, but just recently, 1 month back in ASCO, we had some very good, interesting data coming up regarding the role of immunochemotherapy, not in stage 1, but from stage 2 onwards.
Okay.
There are some very interesting data. What I can say is quite early to comment on this, the role of systemic treatment in early larynx cancer, but maybe in ON 9.0, 10.0, maybe having something.
Right. Okay, last question.
Can I? Yeah. So just a comment. So as rightly said, 30% patient would have a positive tumor after doing the re-excision. But as rightly said by Kaustubh sir, of the 100 patients who have this kind of scenario, 90 would be going for radiotherapy, 10 would be going for surgery, and out of that 10, 30% would have a positive tumor. So we actually don't know. So honestly, we don't know how many would be having a residual disease or not. But we have to be considerate that the ENT surgeons who perform the MLS are also equally trained to work for malignancy. So it is not only the head and neck oncosurgeons, it is the ENT surgeons who also do a good work. So I don't agree that that this patient have to be redo a surgery. We can do it with the radiotherapy also, right. And the results are equal.
Right.
So I think it's a debate which will never end.
That is why we are having Dr. Paretti and Dr. Akshay doing these courses all across the country so that we train more people, because we know that transoral laser surgery might be more cost effective and more efficacious for these patients which have very early lesions. Thank you very much for your patient listening, and
sir,
I thank
sir,
the
one final question, if you don't mind.
audience.
I will be very quick.
Lunch, yeah.
Sir, I will be very quick.
Everybody
Sir.
is hungry.
Sir, I will be very quick, sir. Sir, what is your take on the difference in outcomes for lesions anterior to vocal cord and posterior in terms of laser and in terms of radiation to Savani ma'am also? And what is the specific difference in voice quality?
Second question again.
Sir, please, sir.
Professor
Sir, this is for the audience, sir.
Professor
How much is
Paretti?
the difference in terms of voice quality between smokers and non-smokers when you go for laser or radiation?
So the question is smokers versus non-smokers and anterior commissure versus not.
Yes, of course, the anterior commissure is the key point. If you touch the anterior commissure, the voice becomes worse, of course. In this case, I suggest to the patient radiotherapy, especially if the professional use their voice. The smokers, I always suggest to stop to smoke after the treatment, of course. If they continue to smoke, the probability of a recurrence is higher, and you cannot compare the vocal outcome between smoker and non-smoker. I mean, it doesn't make
Thank you,
sense.
sir. Thank you very much. We'll just have a photograph.
Okay, thank you.
Thank you, Dr. Prathamesh. Thank you, panelists, and thank you, chairpersons.